This lecture was prepared by Dr. Joe Park, an assistant professor in the Department of Emergency Medicine at Hallym University Dongtan Sacred Heart Hospital. This presentation series was developed to introduce and help you understand the PATOS variables of trauma care at ED and hospitals, severity, and outcomes. First, we'll be going over the variables which are related to ED and hospital trauma care. This table shows the PATOS variables of ED and hospital care. This section of PATOS includes some of the variables that are complicated and difficult to collect. However, ED and hospital care data is very important to PATOS, as well as general trauma outcome surveillance. In this lecture, we'll first go over why these variables are so important for trauma surveillance. Trauma or injury is not a momentary event. It rather results in disability and prolonged needs for medical care, as well as wounds and pain. In injury epidemiology, understanding the injury spectrum is very important to develop and evaluate regional or national trauma care systems. Because the availability of community resources is very different across the course of injury spectrum, we need to understand where the most problematic area is in our trauma care system. So this is why we need to have information about the whole spectrum of injury. ED and hospital care usually involves injury incidents to disability or death. If we fail to prevent an event, the next step is to provide proper definitive care to patients to reduce their risk of morbidity and mortality. Trauma care systems may include all acute healthcare facilities. Acute care facilities are the core of a regional trauma care system as it provides definitive care to the entire spectrum of patients. This is why acute healthcare facilities need to be well integrated into the continuum of patient care. To allocate patients to the appropriate facility, all patients need to be triaged first to match their medical needs to the hospital resource and capability. An effective means of trauma care is to prevent an event before its incident. Large gains are to be made in prevention, and there is a major emphasis placed on the prevention of trauma incidents. And treatment is also another effective approach that results in a major gain. Essential trauma care services should be provided to everyone who needs them in a timely fashion. In PATOS, the purpose of collecting ED and hospital care data are to understand the whole injury spectrum status in your region, to understand where your system status is globally, to identify the problem in your trauma care system, to promote manpower, training, QI program, and integration between facilities. Essential trauma care means that life-threatening injuries are appropriately and promptly treated in accordance with the appropriate priorities, maximizing the likelihood of survival. When potentially disabling injuries are appropriately treated, it can minimize functional impairment and maximize the probability of returning to independence and participation in community life. Essential trauma care also minimizes pain and psychological suffering. In PATOS, we have different regions participating in this study. Each region has its own trauma care system, as well as a national healthcare system. Considering the difference between countries, we have created core, comprehensive, and optional variables for the PATOS system. So here is a list of core variables about ED and hospital care. For all patients, we aim to understand their initial state and timely appropriateness of care. This would be done using variables of vital signs and time. For all patients, we'll also collect information about essential core treatment, such as airway management. For core outcome of patients, we'll also collect information such as modified Rankin scale at discharge. For patients who are admitted at hospitals, we'll collect information about disposition, date and time of discharge from hospital, and total length of stay in ICU. These variables are tallies about the length of days a patient uses medical resources at a hospital. Comprehensive variables of ED and hospital care are listed on this slide. For all patients, comprehensive variables will inform us about utilization of essential emergency and definitive care. Pre-existing comorbidity will allow us to compare disability status before and after trauma. And for pediatric patients, we have specialized variables for calculating pediatric trauma score. Type and extent of trauma care depends on the level of healthcare facility. But if you grasp the idea of standard trauma care protocol, it'll help you understand how the PATOS variables were designed in the first place. For your reference, in 2004, WHO published the Guidelines for Essential Trauma Care to suggest the essential lines of care according to hospital level. At basic level hospitals, airway management protocol includes assessment of the airway and manual maneuver. At higher level hospitals, a higher quality of care is provided including airway, suction, BVM, and ETI. PATOS will collect an airway management variable, which will be used for the analysis of essential airway management methods and make comparisons between countries. If we consider comprehensive variables, we can also analyze breathing and compare their results between institutions and countries. Guidelines for Essential Trauma Care states that the treatment of a trauma patient should address airway management, breathing, and circulation. PATOS core variables will collect information on patients' vital signs, which will allow us to identify shock patients. Using comprehensive variables, we can then assess the adequacy and effect of circulation and shock management. While the guidelines for essential trauma care suggest various types of treatment methods, some of their scientific rationale and effects still remain under debate. There is also new and emerging lines of care which had not been introduced by the guideline. This is why PATOS committee has discussed and ended up developing the current variables list. Next up is variables related to trauma severity and outcome. Trauma severity will be measured using ICD-10 diagnosis, AIS, and ISS. ICD-10 diagnosis is the international standard diagnostic tool used for epidemiology, health management, and clinical purposes. It includes analysis of the general health status of a population and is used to monitor the incidence and prevalence of disease and other health problems. Taken together, ICD-10 can illustrate a picture of the general health status of countries and populations. This is the official website for ICD-10. If it is possible, we advise you to follow the codes and definitions specified on this website. In PATOS, we will enter the first alphabet, S or T, followed by a 3-digit numerical code. If your country uses ICD-9 instead of ICD-10, then ICD-9 can also be entered at the website for your convenience. AIS is a coding and scoring system to classify and describe the severity of injuries by 9 anatomical regions. The 9 anatomical regions are head, face, neck, thorax, abdomen and pelvic contents, spine, upper extremity, lower extremity, and external and thermal injuries and other. Now note here that the spinal injury is categorized into a separate chapter, while thermal injuries and other trauma are categorized as a single chapter regardless of the anatomical region injured. For PATOS, AIS will be coded as a 6-digit pre-dot number, followed by a 1-digit post-dot number. The first 6 digits are a unique identifier given to each type of trauma, and the very last number describes severity. Severity is coded 1 through 6, where 1 means minor trauma and 6 means maximal severity. For AIS, we will use the AIS 2005 Update 2008 version, which is the most up-to-date version currently available. This is how the AIS codebook looks like. Once you identify the type of injury on the list, then find and enter the 7-digit number in the first column which corresponds to the injury of your interest. For those countries that use the AIS 98 version, note that you can always convert the AIS 98 code to AIS 2005 code according to the second column from the right. Next is injury severity score, which is widely used within the clinical setting and has become an integral part of all trauma registry-based severity assessment tools. It is calculated as the sum of the squares of the highest AIS scores in 3 different body regions. To calculate ISS, Take the highest AI severity code in each of the 3 most severely injured ISS body regions, square each AI's code, and add the 3 squared numbers. ISS scores are calculated using the following 6 body regions: head or neck, face, chest, abdomen and pelvic contents, extremities or pelvic girdle, and external. Outcome variables are one of the core goals of PATOS. Outcome variables include modified Rankin scale at discharge, Glasgow Outcome Scale measured at 4 different times, EQ5D, and death information. First is the modified Rankin scale, which is a commonly used scale for measuring the degree of disability or dependence in the daily activities of people who have suffered a stroke or other causes of neurologic disability. The scale runs from 0 to 6, where 0 indicates perfect health without symptoms, and 6 indicates death. Methods for systematically determining an MRS score can be described using this flowchart. If there is anyone who wishes to be certified for using MRS, anyone can access this website and take an online course at a charge. GOS before injury and at discharge can be extracted from the medical record. But if not available, coordinators can use the structure survey tool for GOS, which is provided in the data dictionary. This is the structure survey tool for evaluating GOS, and again, this tool can be found under the PATOS data dictionary. Now this is the structure survey tool for GOS extended. Note that this is similar to the GOS survey tool, but there are more specific questions for GOS-E near the end. In countries that do not use English as their first language, we strongly recommend translation of the survey tool into the local language. EQ5D is a standardized instrument for measuring health outcome. It is applicable to a wide range of health conditions and treatments. It provides a simple and descriptive profile and a single index value for a person's health status. EQ5D is primarily designed for self-completion by respondents, and it is ideal for use in poster surveys, in clinics, and face-to-face interviews. It is simply designed and takes only a few minutes to complete. Instructions for respondents are included in the questionnaire. A specific kind of EQ5D is EQ5D3L. It is a descriptive system of health-related quality of life states and consists of 5 dimensions: mobility, self-care, usual activities, pain and discomfort, anxiety and depression. Each of the 5 dimensions can take one of 3 responses. The responses record one of the 3 levels of severity, that is, no problem, some or moderate problem, and extreme problem, within one particular EQ5D dimension. This is a structured survey tool for evaluating EQ5D3L. At the end of these questions, there is a section called VAS, which evaluates health status on a 100-point scale. Education for using EQ5D is also provided on the Eurocall website at a charge. Information about death is extracted from a patient's death certificate. We'll measure date and time of death as well as primary cause of death. So this ends the session on ED and hospital trauma care and outcome variables.